Assalamu alaikum. Our lecture today is about an approach to the diagnosis of the limping child. Limping is very common in children. The diagnostic challenge for the orthopedist. A painful or painless limb may be caused by myriad conditions, from the benign, like an unrecognized splinter in the foot, to the serious septic hip or malignant tumor. The clinician must approach each patient in a systematic and orderly manner to avoid missing or delaying the diagnosis. A thorough history and physical examination are the first step towards achieving this goal. Joints are inspected for irritability, swelling, effusion, erythema, and warmth. The presence of muscle atrophy is noted and measured. Both active and passive ranges of motion are assessed. Particular attention is paid to the child's gait. The need for ancillary diagnostic tests is based on the history and the clinical examination findings. They include lab, radiography, ultrasonography, bone scan, CT, and MRI. If the child normal on physical examination and appears well, the gait disturbance is likely to be self-limiting and radiographs are unlikely to assist in making a diagnosis. Persistent symptoms, however, warrant further investigations. Antalgic gait. It's caused by pain in the lower limb or occasionally in the back. It's generally the most common gait in the limping child. In an attempt to avoid the pain, the child takes quick soft steps on the affected leg, what's called short stepping gait, that decreases the amount of time the lower limb is in the stance phase. An antalgic gait can be caused by any condition that causes pain during weight bearing, and the pain can originate from any part of the lower limb. Another type of gait is Trendelenburg gait. A Trendelenburg gait is observed with weakened hip abductor muscles, a condition that makes it difficult to support the body's weight on the affected lower limb. The gait disturbance is commonly observed in DDH, congenital coxavara or coxavara secondary to other disorders like Pear's disease or slipped capital femoral epiphysis. In all these conditions, the abductor muscles are normal but are at a mechanical disadvantage. As a result, during the stance phase, the hip abductor functions ineffectively and the pelvis tilts. Here is the Trendelenburg test. It is different from the Trendelenburg gait. It is a clinical test. You ask the patient to stand on the affected limb and then on the normal limb. When he stands on the normal limb, the pelvis is elevated on the unaffected side. But when he stands on the diseased limb, the pelvis will drop on the normal side. Proximal muscle weakness gait. Weakness of the proximal musculature as seen in children with muscular dystrophy may cause limping in the older toddlers or young child. The lack of hip extensor strength forces the child to walk with increased lordosis of the lumbar spine to remain upright. Gower sign is often present as the child arises from a sitting position. The child must climb up himself by pushing off his hands against the chins, knees, thighs, and finally the hips. Here the Gower sign, how the child can stand from the sitting position. Spastic gait. Spastic gait, as in cerebral palsy, is caused by hypertonicity and imbalanced activity among muscle groups. Children with CP often exhibit a scissoring gait, secondary to excessive hip adduction throughout the gait cycle. Sustained activity of the gastrocnemius may cause ankle squeeze and too quick walking. A patient with hemiplegia may appear to be dragging the affected lower limb. Short limb gait. Gait asymmetry is usually seen in children with limb length discrepancy more than 2 or 3 centimeters. In an effort to keep the pelvis level throughout the gait cycle, the child walks on the toes of the foot of the shorter lower limb. The child may be forced to maintain the flexion of the hip and knee of the longer lower limb when it is in the stance phase. Here is a table showing the differential diagnosis of limping in various age groups. We divided age groups into toddler 1 to 3, child 4 to 10, and adolescent 11 to 15. The causes in the toddler 1 to 3 years: transient synovitis, what's called irritable hip, septic arthritis, discitis, toddler fracture, CB, muscular dystrophy, DDH. In the elder group, 4 to 10 years, transient synovitis also, which is irritable hip, septic arthritis, Pear's disease, discoid meniscus, limb length discrepancy. In the adolescent, there are more entities coming in view, like slipped capital femoral epiphysis, hip dysplasia, chondrolysis, overuse syndrome, osteochondrite discans. So in the toddlers 1 to 3 years, determining the cause of the hip is very difficult in this group because they are young, so young you cannot take history directly from them. You should depend on the father or the mother, because toddlers often are apprehensive or frightened at the physician office. The least intimidating part of the examination should be conducted first. The examiner should observe the toddler's gait while they are walking uninhibitedly with their parents at the start of their visit to the clinic. Other important findings include localized tenderness on palpation, evidence of inflammation, specifically erythema, heat, swelling, and pain. Painless disorders that can cause limping in toddlers include DDH and limb length discrepancy. Painless to walking in toddler is a common indication for pediatric orthopedic referral. Differential diagnoses include idiopathic mild spastic diplegia and hereditary spastic paraparesis. A thorough evaluation of the prenatal and family histories and the close examination of the gait for underlying spasticity usually identify a neurologic or inherited cause. In the elder group 4 to 10 years, evaluating a limb in this age group is easier than in toddlers as they are more cooperative because children in this age group usually are more interested in play than in ancillary gains. Limping and complaints of pain should always be taken seriously. Parents may report that the child complains of leg discomfort, typically in the evening before bedtime, that's alleviated only after massage and on occasion by medications. Before dismissing such discomfort as growing pains due to the normal growth of the bone in this stage, the clinician should perform a thorough evaluation to rule out an underlying disorder. Adolescent group 11 to 15 years, the limping adolescent usually can provide the clinician with an accurate history. They are old enough to give you valuable information. However, symptoms may be understated if the individual wishes to return quickly to enjoyable activities or exaggerated if the individual hopes to avoid unpleasant physical activity requirements. Toddler fracture, it is a spiral fracture of the tibia without concomitant fibular fracture. It may result from a torsion type of injury to the lower limb, torsion or twisting injury. However, parents may not recall a history of trauma. The child presents with the limb or may resist any weight bearing on the affected lower limb. Initial radiographs may appear normal. When follow-up radiographs are obtained 1 to 2 weeks later, some degree of supraosteal new bone formation is usually seen. Transient synovitis, the other name is called irritable hip because it mostly comes in the hip, is probably the most common cause of lower limb pain and likely responsible for the majority of cases of limping secondary to an irritable joint. The condition is seen mostly in children 3 to 8 years and manifests with rapid onset of hip pain, limited range of motion, limping, or inability to walk. Often the child has a history of unantecedent viral illness. Although the clinical presentation may mimic that of the septic arthritis, patients rarely have a temperature more than 38 or indication of systemic illness, while blood cell count, CRP, ECR are all normal. It is not infection. Ultrasound examination of the affected hip shows the effusion associated with transient synovitis. Septic arthritis, it is more risky than the previous one, transient synovitis. It must be differentiated from it because both conditions produce a limb secondary to joint pain. During the acute phase, it is crucial that the clinician accurately distinguish between the two disorders. The child may walk with a limb or refuse to walk because of pain. He or she may have a history of antecedent mild trauma to the lower limb or concurrent infection or illness. Unlike transient synovitis, septic arthritis usually progresses to a febrile systemic illness, and the child has fever, chills, and malaise. The child holds the affected limb immobile. Swelling of the joint, erythema, warmth, and tenderness on palpation may be present. Passive movement of the affected joint through its range of motion causes pain, as does weight bearing on the affected lower limb. Unless the patient is immunocompromised, lab values will increase. Infection profile, white blood cells, CRP, and ESR. Blood culture results may be positive in the rare changes. Second bone infection typically do not become apparent until after 7 to 10 days, so we do not wait for X-ray changes. In more advanced infection, erosion and joint space narrowing may be noted as the articular cartilage is destroyed. Bone scan is very accurate in localizing the abnormality, but it is not specific. It is sensitive, but not specific. MRI is highly sensitive for detection of the infection. Joint aspiration is very important to corroborate the diagnosis and identify the causative bacterial organism. The aspirate white blood cell count is 80 to 200,000 cells per milliliter, with more than 75% of them neutrophils. Gram stain is helpful in selecting the appropriate initial antimicrobial agent. Commonly, the synovial fluid is culture positive unless the patient has recently taken antibiotics. Osteomyelitis in toddlers and children, it may manifest with localized swelling, pain, or pseudoparalysis, and may be associated with sudden onset of fever and a toxic state. In adolescents, the course may be more indolent, resulting in a delay in diagnosis. Evidence of deep localized soft tissue swelling is often the earliest radiographic sign. Destruction of bone, commonly in the metaphyseal region, usually is not appreciated for several days. DDH, it causes a painless limb in the toddler. The parents often report that the child did not start walking until the age of 14 to 18 months. The child may have lower limb limb discrepancy and may exhibit one-sided toe walking on the shorter side, of course, along with the limb during ambulation. If the condition is bilateral, the child may have a sway back appearance due to the overlordosis of the lumbar spine and walk with a waddle. An abductor large to the affected side during the Nuremberg gait is readily evident when the child stands on the affected extremity. The pelvis sags to the contralateral side down. The patient tries to compensate by leaning over the affected hip, which is the Tenderberg sign. During examination, when the child is in the spine position, restricted abduction of the affected hip compared with the normal contralateral hip may be known. Tumors, don't forget tumors as a cause of limping child. Leukemias, the most common malignant tumor in the children. Lymphoma, also very common, but less than leukemia, of course. Neuroblastoma and even sarcoma. Thank you.